Hello, everyone, and thank you for joining us this afternoon for this first webinar in a three-part series on creating justice-oriented tobacco cessation programs. My name is Jim Pavlik, and I am the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. For those of you who don't know, the HWP provides technical assistance on tobacco cessation and tobacco-free policies to state and county governments, as well as public, private, and nonprofit organizations. This particular series was created as part of our current project with the Colorado Department of Public Health and Environment State Tobacco Education and Prevention Partnership, a program where we take the lead in providing technical assistance specifically on tobacco cessation initiatives. I've been with the HWP since 2013 as a program and data analyst, consultant, and tobacco cessation curriculum designer and trainer. And just a quick disclaimer, to the extent that I express an opinion today, judgment or an analysis, these should be considered my own and not CDPHE's or the university's, and not BHWP's either. I have no other conflicts of interest to disclose. With that out of the way, I am very excited to talk to you today on a topic that I think is of critical and central importance in tobacco cessation work, and that is in identifying and closing health disparities gaps. And those are gaps in tobacco exposure, in use and dependence, also in treatment delivery and in health outcomes. And I want to say at the outset that the reason we must explicitly acknowledge and address injustices and not just disparities is because many of the disparities that we're going to talk about and seek to correct weren't necessarily brought about by accident. Much of the current tobacco use environment, from adverse childhood experiences that provide access to and encourage experimentation with drugs, including nicotine, to targeted tobacco industry campaigns, to early detection and screening systems through care provision, and outward to continuity of care systems and care follow-up. They were all designed to exploit existing inequalities or deliver care in unequal ways. And even in those cases when disparities were not the product of design, they were often the outcomes of supposedly or rhetorically neutral systems that were built on top of deliberately unjust foundations, which is to say that even when we say that some of our current disparities are the result of neglect, we need to recognize that some of that neglect is benign and some of it is malignant. But in order to create a justice-focused nicotine cessation program, we first need to understand what a conventional nicotine cessation program is and how the two might differ. In short, a public health-driven cessation program includes a set of coordinated policies and activities designed to motivate and support quit attempts in the population. It turns out that in terms of motivating quit attempts in the population, public health has some pretty powerful tools, not perfect and never perfectly applied, but powerful nevertheless. In terms of supporting quit attempts, there's quite a bit more work that can be done. And work in this area is critical to identifying and addressing disparities in nicotine use and the related health outcomes. Nicotine has specific characteristics that lead to specific use patterns and a unique dependence profile. And this unique dependence profile can help explain why public health has been so successful at motivating quit attempts, and also why the tools that are so good at motivating them are frequently insufficient for sustaining them. And this in turn can help direct cessation programs towards supporting and promoting those strategies that can. This webinar is the first of 3 on developing a justice-oriented public health response to nicotine use dependence cessation and the health outcomes that derive from that use, dependence, and cessation. To lay out the case for why we need justice-focused cessation programs and to encourage creative problem solving to address health disparities, this series will first establish what a public health tobacco cessation program is and how they work when they work. Then we'll move on into identifying the disparities in certain but not all groups. And finally, we will outline in broad strokes what public health needs to do to close existing health disparities, and ideally without opening up new ones in the process. I will introduce or reintroduce you to several resources along the way. But today, I'm actually going to start us off in what I think is a peculiar place for a webinar series that is ultimately about designing a public health response to tobacco use and its various disparities. I'm going to start us off by making the case that as it pertains to designing a competent response to nicotine use, we have vastly underappreciated just how addictive nicotine really is. So we're going to go all the way down to the individual level. And while we're down there, I'm going to spend some additional time exploring other unique features of nicotine's use profile so that we can appreciate how, even for seasoned addictions professionals, nicotine presents unique challenges to care. And from there, we will place cessation efforts within larger tobacco control efforts and define precisely what we mean when we're talking about cessation. And finally, we will briefly review the evidence-based strategies for treating tobacco dependence, because ultimately, our justice-focused strategies have to be aimed at increasing trust in, driving people to, and connecting people with skilled practitioners of evidence-based care. So one more quick word on who this first module is aimed at. I've been doing this work for, as I said, about 10 years, and I've been in public health for another 6 years on top of that. In my experience, the turnover rate in tobacco control is so high that many people are now getting introduced to what seem to be pretty old resources, and they don't really understand the practice-based trials and errors that went into creating them. I think recapitulating a little bit of that history can add valuable insights into what our current toolset is good for and where it falls short. And this is an important starting point for discussing what's needed to address tobacco-related health injustice. So in my opinion, this webinar is an introduction to evidence-based public health tobacco cessation interventions and is, as such, good for individuals just starting out. I hope it's also good for, or at least interesting to, veterans of tobacco cessation who may be inspired to think about old tools in new ways. I also think it's worth taking a moment to ask why this webinar series exists, why the HWP thinks it's important. Obviously, there's something very of the moment in framing tobacco cessation in terms of justice or social justice or health justice, but it's more than that. In fact, the HWP has been talking about tobacco cessation explicitly as a social justice issue since it was formed in 2006. And it was largely this social justice perspective that brought me here. My own personal background in public health began initially as a neighborhood advocate working in the community empowerment domain. The HWP's specific focus has always been on the ways in which our public health infrastructure has failed to achieve the same success among individuals with a behavioral health condition as it has had with the general population. And over time, that work has expanded into several other areas of inequities with a focus on both criminal justice systems and among individuals experiencing or at risk of experiencing houselessness. Often in our world, we talk about this disproportionate impact in an accusatory tone, one that's not entirely undeserved, but it also isn't the entire picture of what's really going on. There are deficiencies in the current public health infrastructure that practically ensure that without reform, certain individuals will be systematically underserved. But the other side of the story, I think, is often framed improperly, or to the extent that its critique is also accurate, is itself incomplete. The story is, and I told it myself this way, is that a general population level intervention, such as the publication of the first Surgeon General's report on smoking, was disproportionately impactful among white men. And as a result, this caused the disparities that we see today. And in a kind of trivial technical sense, this interpretation is correct. The fact that a lot of white men did stop smoking in the first few years after Surgeon General Terry's report did mean that there were suddenly prevalence rate gaps between, say, white and Black Americans that did not exist when about 60% of all men smoked. But to wag a finger at public health's inattention here seems just a tiny, tiny bit misplaced. To leap to blaming public health is just a little too easy, actually. It is true that the impact was largely among white men, but why? Why would this objectively written report detailing scientific findings and written at a moderately educated middle-class reading level fail to resonate outside the narrow confines of moderately educated white men? And I'm being slightly tongue-in-cheek. But I am, if obtusely, trying to point to factors that made this report fail to resonate outside that particular audience. If 1964 America had been more egalitarian, if more Black Americans at the time had been moderately educated, if more Black Americans had already been middle class, if more Black Americans had had TVs and access to the findings of the report, then perhaps it would have had a larger and better impact than it did. But 1964 America was not those things. 1964 America was Jim Crow America, and Jim Crow America was built on the rubble of Reconstruction America, which was built on slaveholding America. Centuries of injustices had already been in place and running their course when that 1964 report was being publicized. And I know that can sound a little apologetic, but I don't think it removes public health's accountability to say it didn't singularly construct a system that largely paid dividends to white men with money. There were plenty of deficiencies that public health could have rectified before that report. There was no data justice, a topic I'll return to later in the series. The Office of the Surgeon General, to the best of my knowledge, wasn't tracking differences in prevalence rates among white and Black Americans, although they were tracking differences between men and women. And they weren't just ignoring differences between whites and Blacks, but also between whites and Latinx and Asians and Native Americans, nor were they looking at occupational differences, sexual orientation, religious difference, and on and on and on. In the blinkered vision of mid-20th century American governance, there was simply one American public, and it was imagined to look like white men, and therefore presumably would act that way when they were presented with data. So I'm not trying to be apologetic. I am, however, hoping to interject some nuance here, because it's in these nuances that we can get to potential solutions. We forget, I think, or fail to prioritize the fact that tobacco use cessation and our public health attempts to address those issues are altogether caught up in the same stream of socioeconomic injustices and long-standing path dependencies that, without explicit attention, will turn even honest attempts to fix things into a mere perpetuation of past transgressions. Which is all to say, I want to start off this presentation with a clear pronouncement that good intentions in this space simply are not enough. It was not just the case that white men had access to the report. It was also that level of intervention, a standoffish government report, was persuasive and effective in getting some folks to quit. Over the course of the next 40 years, many more such reports came out, and new public policies were adopted, and social norms and expectations changed. And during that time, with the exception of the gap between men and women, many of the gaps that we're concerned with today actually got wider and wider. Why? Why was education and policy good enough for some, but not for others? Relying on education to change behavior implies a very specific theory of change. What it claims is that people make choices based on the knowledge they have. New or different knowledge will naturally lead to new or different behaviors. For those curious, the slide here is from the webinar pictured on the left, part of our three-part series on the health neighborhood. In the case of changing tobacco use and cessation behaviors, the idea is that if the government states clearly and loudly enough that smoking causes heart attacks and lung cancer, that secondhand smoke is the leading cause of infant deaths, that smoking causes dozens of illnesses, including 6 of the top 10 killers in the country, that it rots teeth, that it can lead to hair loss, infertility, birth defects, asthma, amputations, then people will simply choose to do something else with their time and money. And consistently, this strategy does work for a minority of smokers. The reality is that the reality that we needed tailored solutions for more intense levels of dependence and complex medical conditions began to emerge in the late 80s into mid 90s. 3 important things were rising in importance during this time that are important for today's dive into justice-oriented cessation. Beginning in the 1970s, we began getting what would be called in the 90s evidence-based medicine. It seems ludicrous to think that prior to the 90s, this was not a thing. And it's not to say that doctors before Bill Clinton's second term were magicians relying on divining rods and scrying pools to determine which of our 4 humors needed to be balanced. Medicine, as we understand it today as an applied science, goes at least as far back as the classical Greeks and back even further to Arab, Persian, Indian, and Chinese practitioners. But the concept of evidence-based medicine, making choices based on epidemiological evidence and statistical likelihoods and guided by decision trees, all of that was fairly new. The second of these was the development of the concept of the social determinants of health. And again, the idea that social inputs influenced health outcomes was something that was noticed casually by any observer of the human condition going back centuries. But in the 80s and 90s, researchers in the social sciences began to formalize models and try to measure the relative impacts of different socio-environmental inputs. Such models, as with all models, they were, incorrect or imprecise, but they were useful. And in particular, they were useful in creating the concept of risk factors for unhealthy behaviors when hereditary causes of addiction proved to be incomplete. And that leads us to the third thing that was happening in the 80s and 90s. This final crucial advance for this era was determining scientifically that nicotine was indeed addictive. Now, I rush to add that the tobacco companies knew this fact for practically the entirety of their existence, but they were able to craft disingenuous statistical defenses to combat that claim. It was only with the intense efforts of several researchers and their clinical experiments that the evidence from the objective public scientific community became irrefutable. I do rush to add that even in the face of this irrefutable evidence, the tobacco companies did in fact continue to refute it, right up until their private memos were made public and decades of admissions came flooding out. And it seems like such an obvious thing today to say that nicotine is the addictive agent in cigarettes, but this debate was only settled within the last 30 years. What we need to understand first and foremost is that addiction hijacks one's ability to act rationally. Some experts have even explicitly called addiction not just a recurrent chronic disease generally, but a disease of learning and memory, or a disorder of choice. And whether you endorse a disease view or a disorder view, the point here is that drugs impact the parts of the brain or the processes of the brain that might lead a person to choose recovery or to sustain it. It is possible to overcome this damage, but drug use itself encourages future drug use and separately depresses the ability to make a different choice about future drug use. Which is all to say that before we even consider the role of systemic racial and income injustices, we need to understand this, that education as a primary means of achieving a public health tobacco cessation goal is incomplete. It is doomed to succeed mostly with those who need the least assistance, and frequently, maybe even mostly, fail among those who need the most help. And this may have been a fine enough compromise when the minority of smokers was still a lot of people, because that meant millions of new quits every year with extremely little effort, relatively speaking. But important for us today is this: if dependence is both widespread and disproportionately distributed, then public health efforts, no matter their intentions, will also be disproportionately effective. Most adults who use nicotine, and probably most adolescents who regularly use nicotine, are addicted to nicotine. And this is going to fundamentally undermine the success of education-focused interventions. This distinguishes nicotine from other drugs of abuse. And this is a strong claim, by the way, for me to make. So I want to spend some time here developing it. The case I'm going to make is important for tobacco cessation program designers and managers to know, to help them design more effective programs, to design justice-focused programs, and to make the case for such programs to their key constituencies. In fact, the case I want to make here has actually been established, although we don't explicitly continue to establish it as much as we probably need to be. It's very similar to the one paraphrased here from Hughes and colleagues in 2006, that nicotine dependence is a barrier to cessation, that if dependence is high, then a public recommendation for treatment makes sense, and that failing connecting individuals to treatment will result in being disproportionately effective in populations where dependence is low and disproportionately ineffective in populations where dependence is high. We're often asked why we should prioritize tobacco, or why we should ask that it share center stage with other more high-profile drugs of abuse like heroin. The fact is that nicotine is unique, and it is uniquely dangerous. More people experiment with tobacco than any other drug except alcohol. Nicotine is, depending on how you measure addictive potential, as addictive as heroin or methamphetamine or more. The half-life of a nicotine addiction, which is to say, when did 50% of individuals who have a habit quit that habit? The half-life of a nicotine addiction is longer and more linear than any other drug. And a point I'm going to look into in more depth in just a moment, more users of nicotine are addicted to it than are the users of any other drug addicted to their own drug, to those other drugs. And as a result of this combination of factors, nicotine is deadlier by far than any other drug. And those of us in tobacco control, right? Those of us who are on the line today, we tend to focus on this last element, the premature morbidity and mortality of tobacco use. So we hold up figures like 106,000 deaths from opioids last year, driven by fentanyl, and compare it to the 500,000 deaths from tobacco last year, and every year going back decades. And it's hard for us not to see that at the very least, tobacco deserves to be as highly prioritized as opioids, given that they cause 5 times the amount of deaths every year as opioids caused in their worst year. But we think, I think we understand the opposing reality too. Tobacco does seem like a lifestyle choice, more than heroin addiction does. The deaths from opioids occur within days or a few years of use, as opposed to after 40 years of daily use with tobacco. Many opioid deaths are among younger people, whereas most people who die from cigarettes do die 10 to 15 years younger than they would have otherwise, but that still means they die in their 50s and 60s. Deaths from opioids, and especially the rapid rise in the deaths from opioids, is shocking and tragic, and it could be an ominous sign of deeper fractures in our delicate social web. Tobacco, on the other hand, has been slowly killing its users since our great-grandparents were born. But the fact is that tobacco is unique and it's uniquely dangerous. And frankly, I don't know of anyone in the tobacco control field that thinks we should ignore the opioid crisis. In an ideal world, no one dies from drug use, whether that drug use is recreational or medicinal, chronic or acute. And in fact, as we go further along in this series, we'll learn a key way to prevent deaths from both opioids and tobacco is to recognize that dual use is extremely common, and that treating all drugs of abuse at the same time increases the odds for long-term abstinence more than treating any drug in isolation. The majority, and by some measures, the vast majority of nicotine users are in fact addicted. And the risk of addiction is partially determined by socio-environmental factors that disproportionately burden certain segments of the population over others. Developing a justice-oriented tobacco cessation program must take into account both of these facts. And it's impossible, it's hard, maybe even impossible, to determine what the historical rate of tobacco dependence has been. For one thing, the diagnostic criteria has changed over time. Even within just one manual, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, there have been radical shifts in the diagnostic criteria used. And as a result of these different definitions of dependence, different inferences of prevalence rates of tobacco or nicotine dependence have been calculated. Using the criteria defined in the DSM-3, which existed in various forms from 1980 to 1994, researchers determined that 9 to 13% of all adults were dependent on nicotine in 2005. And that works out to about 50% of what at the time were current tobacco users. Now, personally, Jim Pavlik speaking here, I think to find out that a full half of a drug's users are actually dependent is astounding. That's an astounding number. And while the numbers are certainly hard to come by, this is far more than any other common drug of abuse. Hughes, Helzer, and Lindberg mention several reasons why they may have underestimated the actual prevalence figure. And we'll get into some of those reasons in passing as we go along. The point for now is this, that although 50%, if true, would be absolutely staggering, it is almost certainly a low-end estimate. Dependence can be defined and measured in different ways, but I think the most useful definition, and one that can apply with just a little modification to youth as well as adults, is simply this. What are the results if one tries to abstain from use? We know that historically about 70% of US adults want to quit within the next 12 months. And first of all, that is also an astounding figure, that 70% of tobacco users are continuing to smoke despite wanting to quit. And of those 70%, about 81% of them will try to quit within the next 12 months. And I don't want to be accused of using percentages for dramatic effect. That works out to about 55% of smokers who try to quit every year. So using wants to quit but is currently smoking as a measure, we move from 50% to something more like 55 to 70%. And this range has been consistent for every year, going back at least a generation, back to the year 2000. But other estimates are even higher. The American Academy of Addiction Psychiatrists claims that between 60 and 80% of tobacco users qualify for dependence. And the author of the book, The Golden Holocaust, puts that number at 80% as well. A couple of things worth noting here before moving on is that Hughes, Helzer, and Lindberg noted that dependence appeared to be higher in populations with a higher baseline prevalence rate. And studies out of both Sweden and Nepal have indicated higher levels of dependence among users of smokeless products. And while neither of these are necessary important pieces of information to describe the quote unquote average tobacco user or to design tobacco cessation programs for that quote unquote average user, either or both of these do become important when we begin to consider how we might design programs for marginalized communities where prevalence rates gravitate toward 200 to 300% greater than the general population or more, and where use of alternative products often outpace the prevalence of cigarettes, as is the case in many rural counties. So I'm going to switch gears a little bit and expand the topic away from dependence and toward the broader category of tobacco use disorder. First, let's just consider what these words mean. With our range of tobacco dependence among tobacco users at certainly more than half and potentially up to 80%, we are presented with a further issue. And that is that while dependence itself is bad, it isn't the only matter of concern when it comes to tobacco use. Tobacco can cause dozens of illnesses, regardless if the tobacco user is dependent or not. And outside of the physical costs of tobacco use, tobacco can cause mood disruptions and emotional distress, even if the threshold for dependence is not met. So what we're talking about here is that tobacco use may cause problems, even if the individual is not, quote unquote, dependent. And that's fine. But personally, when I review the 11 criteria for tobacco use disorder pictured on this slide, which I know is hard to read and small, only two, a person only has to get 2 of these in 1 year to meet the criteria for a diagnosis of tobacco use disorder. And it's hard not to see that fundamentally, if tobacco use is causing a problem, then a quote unquote rational person would simply quit if they could. We make these kinds of choice trade-offs all the time. It's only when the ability to quit or the ability to choose to quit is impaired that we can really see a problem. Take number 3, for example, spending a lot of time trying to get nicotine. This isn't a problem, right? I know it sounds like a problem. It's written in a list of potential problems, but consider your relationship to any of your hobbies. I spend a lot of time trying to draw birds, but I want to be able to draw birds, and I like spending time drawing them. It simply isn't a problem that I, quote, spend a lot of time drawing birds. It becomes a problem when I spend so much time drawing birds that I fail to accomplish necessary tasks, or I stop doing other things that I enjoy, even though I still want to do them. It becomes a problem when I can't stop drawing birds when I want to stop drawing birds, which is to say that I think it's worth spending some time thinking of these other diagnostic criteria for tobacco use disorder, because more often than not, if tobacco use disorder is present, then dependence is probably likely to be present as well, even if it's unacknowledged. We should consider that tobacco dependence was not even a diagnosable condition until the DSM-3. The first DSM was published in 1952 and the DSM-2 in 1968. So its inclusion in 1980 can generously be said to be tardy. From the DSM-3 and through the DSM-4, which was in use between 1994 and 2013, tobacco dependence was the only thing that we could diagnose. Addiction professionals now know that dependence to nicotine can occur even if the individual does not smoke every day, and even if their volume of use is quite low. Contrastingly, some individuals, for reasons we cannot fully explain, may escape dependence even if they smoke in excess of a pack or more every day. Dependence itself, then, just doesn't provide a full enough explanation for tobacco-related behaviors. The DSM-5, as I mentioned, includes 11 diagnostic criteria, of which the tobacco user must meet 2 in a 12-month period in order to get a diagnosis or qualify for a diagnosis of tobacco use disorder. And I would hazard a guess that nearly all tobacco users experience 2 of them quite early on in the development of their habit. Consider these 2 facts. By the age of 18, half of those who regularly use tobacco have tried to quit and failed. That already meets 1 criteria, the one on the screen right now. And then take a look at this chart of the 4 principal smoking trajectories. On the x-axis here, you see ages in years and then how many cigarettes per day each of them are smoking. And what this shows you is a pattern of increasing use in 3 out of these 4 trajectories. And that meets a second criteria, right? That's tolerance, the one pictured on the board now. In fact, for decades, well before the inclusion of tobacco use disorder in the DSM, researchers knew that tobacco use negatively influenced people's lives well beyond what the estimated prevalence of tobacco dependence could explain. In 2017, Premature et al. Found that 82.4% of smokers reported high or very high discontent due to their inability to quit. And this discontent was frequently accompanied by reports of low health or the fear of contracting a tobacco-caused illness like lung cancer. And now, depending on how this information may have been reported to a psychologist or psychiatrist during a session, it could qualify as 2, 3, or more of the criteria for tobacco use disorder. I've listed one on the screen. And according to some surveys, Fong et al. From 2004 is one of them, as many as 90% of current tobacco smokers regret having started. As you can see from one of the headlines here, this experience of regret is actually considered universal or near universal. Regret of having started smoking was disproportionately found in lower income groups over higher, among less educated groups over more educated groups, and among women over men. The very vast majority of those experiencing regret want to quit within the next year, about 45% or so, or quote unquote someday, and that's about 40%. Only about 13% of those experiencing regret say they never want to quit. Which is to say that when we're thinking about designing a cessation program, we need to understand that our job isn't really to convince people to quit. By and large, most people regret having started, about 90% or so. About 70% of them not only want to quit, or about 70% of them want to quit, and about 3/4 of them or more want to quit within the next 12 months. So we really only have about 2 main objectives. One is to encourage those individuals, the ones who already want to quit, to access evidence-based resources and to understand that whether they know it or not, they're likely dependent on nicotine and they're likely going to need more assistance than they think they need. So what have we accomplished so far? Well, basically this. We have established, and I hope conclusively, that most individuals who use nicotine, whether they know it or not, are actually dependent on nicotine. And that this is true both for adults and for adolescents, at least adolescents who exhibit regular use patterns, even if they use small amounts and or if they have large gaps between consumption sessions. And what this means is, because of the nature of dependence, that low intensity interventions like education or awareness raising campaigns that tell individuals the harms associated with tobacco use, those are likely to be too light of an intervention for most nicotine users. They're going to be more effective in lightly dependent or non-dependent users, the minority of users, and that these lightly or non-dependent users are disproportionately allocated in already well-resourced areas and among relatively more privileged populations. And we have alluded to the possibility that dependence is actually more common within populations with higher baseline prevalence rates. And as such, interventions not specifically geared toward treating dependence are a major reason we see the use and cessation disparities that we see. And therefore, if we don't pay attention to this aspect, we run the risk of making those same disparities worse. And we're actually going to explore this aspect of it in more depth in the second webinar. We've also established that most users, despite or even because of their dependence, want to quit. They are already motivated to quit. In fact, over half of smokers will try to quit in the next 12 months. So the goal of public health campaigns does not have to focus on enhancing motivation among most tobacco users. The impact on physical health, mood, emotional stability, leisure activities, the pocketbook, their sense of self-worth and personal agency, all of those things tend to keep motivation fairly high among tobacco users, and the more nicotine they use, the higher their motivation to quit is. And that brings us to chapter 3. So enough on what public health campaigns don't have to do. Let's talk about the goals of an evidence-based public health cessation program, and at least introduce the concepts of how we may modify the general approach to close existing disparities and hopefully not open others along the way. And to start this section, the first resource I want to introduce you to, or reintroduce you to, hopefully, is the one pictured here. In 2014, the CDC published the guide, Best Practices for Comprehensive Tobacco Control Programs. And this resource should be familiar to you if you've been working on a STEP grant for a little while. This document serves as the backbone in many ways to the previous LPHA core framework, and it's likely to have a continued presence in the one currently being revised by the STEP team. If you are working in a goal area, you will see that the goal areas are pulled more or less directly from this document, or at least they are reflected here. At 144 pages, this downloadable PDF may seem a bit intimidating, but over half of it is funding recommendations. Both the formula used to calculate those recommendations and the calculated totals are both outdated. And for some of you, they still may prove useful guidelines, but for most of you, I think you can stop reading around page 70 or so. And in those first 70 pages, you should glean a useful introduction to the goals of a statewide tobacco control effort and the evidence-based strategies that can be reasonably expected to work toward those goals, at least from a sort of a broad or general perspective. I want to emphasize this sentence from the executive summary at the beginning of the guide. These individual components are most effective when they work together to produce the synergistic effects of a comprehensive statewide tobacco control program. As I have been and will continue to devote the entirety of this series talking about cessation, it could leave you with the impression that I think cessation is the most important component, or maybe in fact that I think cessation is the only one worth discussing. And I want to clearly say that I do not believe that at all. I instead believe this, that all these components need to exist to get the most effect, and that the loss of one of these components is greater than the cost saved by eliminating it. It just so happens that I work at the Behavioral Health and Wellness Program, the entity with the statewide contract to provide technical assistance in cessation. And this is a cessation-focused series, so that's what I'm going to talk about. So before going into cessation specifically, the 5 components of an evidence-based tobacco control program are, according to this guide, state and community interventions. And this is the most vague one, so it's worth diving in just a little bit here at the beginning. The 3 things they're really talking about here are promoting cessation, preventing initiation, and eliminating secondhand smoke exposure. Then there's mass reach health communications. And then the next step down is the cessation interventions. And because promote cessation is currently in orange on the slide because it appears in the guide under state and community interventions, it's worth pointing out that promoting cessation and actually performing a cessation intervention are different things, right? Primarily, what this goal says it's talking about, this is according to the CDC document, they're talking about promoting health systems change, which is what we call the health neighborhood now, expanding insurance coverage of evidence-based cessation treatments, and supporting state quitline capacity. And then the final 2 sections are infrastructure and admin and surveillance and evaluation. So this is not a situation, I hope this is clear, where I'm not trying to offer the Cliff Notes of this document so that you don't have to engage with it. This is an important document, and I encourage everyone working in tobacco to understand it well enough to critique it. Being able to offer thoughtful commentary on what it gets right and what it gets wrong and what it got right in 2014, but that's changed because of shifts in the tobacco landscape. All of these things can help you better understand how your region's tobacco control efforts fit within the statewide context, and perhaps where there might be opportunities for better cooperation and opportunities for innovation at your or the state level. So, as I say so a lot. So as we drill down into what evidence-based cessation focused strategies are, we're going to be concentrating on the 2 things that appeared on orange on this in the last slide, promoting cessation on the one hand and promoting health systems change on the other. Expanding tax coverage and supporting quitline capacity are for the most part happening elsewhere, other departments at other levels of intervention. Although I do want to point out very quickly that promoting the quitline is a part of promoting cessation. Okay. So now that, now I'm gonna start laughing at myself how many times I say so. Now that we have done some work in separating cessation out from a larger control effort, I'd like to spend some time making the lines between cessation and other related or tangential or overlapping strategies just a bit brighter. This begins with separating out those components that are cessation specifically and primarily, from those that simply are not cessation at all, or where cessation may be a secondary effect or an unintended side effect or that kind of thing. And the primary split here is one I think everyone is aware of to some degree, but I just want to bring it up to the surface a little bit. I'm talking here about numbers 1 and 2, promoting cessation on the one side and preventing initiation on the other. And in broad terms, what we do here is we have cessation and we have initiation, and we direct cessation at adults and initiation at children, right? Individuals younger than 18 and really maybe even focused younger than that, around 15 or 16 or younger than that. So these 2 dimensions, right? Prevention and cessation on the one hand, and these 2 age groups on the other, that gets us most of the way there in sort of understanding what's going on here. But what it misses can be really informative for program designs. The first is that while we say the average age of initiation is 15 to 16, we know that experimentation can happen much earlier. And early experimentation at younger ages can tell us a lot about social structures and the underlying comorbidities that may be acting as risk factors leading to future addiction. This is going to become important in the next webinar when we discuss disparities associated with initiation and experimentation and use, and the relationship those things have to upstream risk factors. The second is that regular recreational use of nicotine may go on for years before it becomes a problematic habit. I'm gonna put that in quotes, a problematic habit. I wanna draw that out, that distinction a little bit more. Because normally in this field, and I've been doing the same thing up until now, we've been talking about addiction and dependence, and now I've introduced this new phrase, a problematic habit. And you'll hear some experts make distinctions between addiction and dependence. They'll say dependence is a physiological term describing adaptations made by the body in response to exposure to a drug, and it's characterized by the development of tolerance to that drug, and it is frequently accompanied with various withdrawal effects, including craving for the drug. Meanwhile, or on the other side, by contrast, there's addiction. And addiction is a psychological term describing behaviors associated with drugs, including drug-seeking behaviors. And I'm highlighting those two things, right? Cravings on the one hand and drug-seeking behaviors on the other. Because both of these terms, addiction and dependence, can be somewhat troublesome. It's hard to draw a line between the physiological components and those behaviors which are regularly and predictably associated with those physiological components. So I just prefer to use the term problematic habit. And I like this term because in accordance with the principle of meeting people where they're at, and what is now also embodied in the definition of a psychiatric disorder in the DSM-5, a problem is only a problem if the person who's supposedly afflicted with it finds it to be problematic, right? The short version is if the person persists in drug use despite experiencing the drug's negative effects, or despite trying to and being unable to change their drug use habits, that person is suffering from a tobacco use disorder. The shorter version is if the person feels they need help to change their drug use, then that person has a drug use disorder. And I don't really care if you want to call that an addiction or a dependence or something else. I like a problematic habit. And then I add the caveat that the person who calls it problematic is the tobacco user themselves. One thing we have to understand here is that the problematic nature actually develops much earlier than we often recognize. So when we say prevention, what are we preventing? The simplest way to think about prevention is that we are preventing exposure, or perhaps preventing experimentation to nicotine, to exposure to and experimentation with nicotine. But if that's the goal of prevention efforts, then I think statistics would say that our prevention efforts largely fail. The majority of 18-year-olds have tried tobacco. Now, on the other hand, if what we're preventing is the type of regular use that leads to dependence and addiction, and if that's what we're measuring, then by that measure, our prevention efforts seem to be pretty successful. Most teenagers who experiment with nicotine do not become adults who are dependent on it. However, it's worth noting that throughout the entire decade, pictured on this slide, of a person's 20s, most individuals who do regularly use have not yet established the actual daily regimen that will define their relationship with tobacco for most of their lives. So if we think of prevention as derailing the formation of that habit, then we need to expand prevention well into young adulthood. Similarly, since it's regular use and not intensity or frequency of use that leads to dependence, and since dependence develops well before most people are aware it has done so, we also need to have a much broader concept of when cessation is applicable, which is to say that there's a period of time, roughly between the ages of 15 and 24, where prevention and cessation strategies are both working in tandem. Then we have, so leaving that section aside, we have all those strategies that are just not cessation strategies per se. They don't have cessation as a central goal, but they often have an impact on cessation attempts. Price controls like price floors and taxes, all of our retailer regulations like licensing and location restrictions, point of sale regulations, also age restrictions, and also all of our smoke-free laws or organizational policies. All of these serve to make using tobacco more costly in terms of time or money, or directly limit who can buy the products. right? And all of these will have a desired goal of changing our social norms around tobacco. These have all been shown to reduce the frequency of use as well as the volume purchased. Making the products more costly serves to prevent people picking up the habit. That's prevention, right? And it may be reducing dependency, the intensity of dependency among those who use. And it definitely encourages those who are already considering quitting to go ahead and give it a shot now rather than later. And for a lucky few, these induced quit attempts are going to be successful. So we say these strategies have an indirect effect on cessation, or that cessation is a secondary effect of these strategies. With a clearer picture now of what cessation is and what it is not, I want to drill down on what precisely a public health cessation program should have as its strategy. If we keep at the forefront of our mind that to promote cessation does not mean motivating people to quit, but rather making cessation resources available, or to the extent that they are already available, then we want to make them more attractive, then we need to have a good sense of what an evidence-based cessation resource is. And these are they. It's coaching, it's counseling, it's medication. The coaching or counseling can come in many formats, including one-on-one, which is to say individual sessions with a tobacco treatment specialist, or a licensed counselor, or a therapist, or from a medical doctor or other qualified professional as determined by Medicare, Medicaid, or any of our insurance payers. Group counseling in the form of psychoeducational groups or tobacco cessation classes. These are normally led by or presided over by a medical doctor or other qualified provider. And telephonic counseling, right, from the state quit line, or not just telehealth is not just limited to the quit line, but also any telehealth operation with a therapist, counselor, doctor, or again, another qualified provider as determined by the medical payer. And then of course, finally, medications. As with all substance abuse disorders for which medication is an option, medication-assisted treatment for nicotine dependence is considered part of the gold standard of care. So we're going to be digging into this area a bit more in the third webinar, but for now, I do want to emphasize, like sort of correct myself a little bit, that public health cessation programs still have a need for education, awareness raising, motivational enhancement, communicating the harms of tobacco, and all those things that I sounded a little dismissive of up to this point. But these things are never deployed alone. They are always deployed in the service of attracting people to the things on this slide, the evidence-based treatment. So why did I go through all of this? Why make the distinction between cessation and prevention so plain, while at the same time confound the issue by recognizing the age where the two strategies overlap? Why take the time to separate cessation strategies from the strategies where cessation may happen indirectly or as an afterthought? And it's because this series is on cessation and cessation strategies. And also because the CDC guidelines that I've already linked to, and they're shown here, right? They present a real muddled picture of what we should be working on. And I want to clarify that picture. The CDC best practices lists several potential goals of a community organization focused on tobacco control. And those are the ones listed here in blue, right? But what specific actions follow from each of these general tobacco control goals can shift markedly if we change the focus of the goal. For example, what issues do we want to keep before the public? Well, if our goal is a flavor ban, then the issues that we may want to keep before the public are the tobacco industry's deliberate weaponizing of flavors to hook children. And we want to keep the statistics of the popularity of flavors among children in the forefront of the minds of the public in the hopes of mobilizing folks behind that flavor ban. But if our goal is to reduce the racial inequities of infections and deaths after an elective surgery, then we might want to highlight the role of smoking in surgical recovery to try to raise support for additional trainings around parasurgical teams. If we want to educate policymakers, number 5 on the board here, what do we want to educate them about? If we want more prevention measures, then we need to educate policymakers about the goals and evidence-based strategies for prevention. If we want better cessation outcomes, then we might need to educate them about the role of reimbursement rates and giving qualified providers the proper incentives to perform value-based care. I, for example, am advocating today that a cessation-focused tobacco program must have a deep appreciation for the role of addiction as the main explanation for tobacco-related behavior and the difficulty in stopping. The CDC guide, as good as a resource as it is, provides a muddled picture of where cessation interventions are. I'll give you one more example. As I mentioned earlier, under state and community interventions, it lists promoting cessation. That seems simple enough. And then I, just a few minutes ago, took the time to explain that promoting cessation appears there instead of under cessation interventions, because promotion of a cessation strategy is a community thing, whereas performing cessation interventions is a health systems thing. But in the CDC document itself, which I still say is good, it says, and I quote, this is under cessation interventions, it says, promoting cessation is a core component of a comprehensive state tobacco control program's efforts to reduce tobacco use. I kind of laugh. My comments here are, I hope, used to provide a clearer picture of cessation-focused strategies than our governing resource does. This picture, I hope, will become even clearer as we go along. What I want you to take away today is that there are lots of admirable goals in tobacco control, and many of the same mediums, methods, and modalities can be used to achieve multiple goals. During this series, we will only be discussing those goals that have cessation at their heart, at their core. Fundamentally, that means increasing the capacity of healthcare systems to treat nicotine dependence on one side, and as it pertains to justice, making sure that those systems are doing the things necessary so that they are trusted by historically disempowered, disenfranchised, exploited, oppressed, or otherwise marginalized communities. So let's bring this all the way back up to the top. Where did I begin today? I began by saying that there were three important shifts in the way that we think about health delivery, and nicotine treatment in particular. And this shift was happening in the 80s and early 90s. The third of these shifts was the definitive proof that nicotine was addictive, and was the primary addictive ingredient in tobacco products. Prior to conclusive evidence that tobacco products could cause addiction, there was no diagnosis for nicotine dependence and no way to measure just how addictive cigarettes were. It's not at all coincidental that the first two DSMs, in effect from 1952 to 1980, failed to acknowledge a dependence condition related to tobacco products. Once addictiveness was established, we could then try to determine just how addictive these products were. And as we've seen today, the answer is very addictive. 55% of tobacco users are dependent by the lowest possible estimate, an estimate that the researchers who established that number admit to being surprised at how low it was. And they also mentioned several reasons why their number may underestimate the actual percentage. That figure could be as high as 90% or maybe even more among adults generally, and among adults in our disparities communities in particular. What we haven't done so far today is talk about why this number is important or how it relates to the two other things that were rising in importance at this time. So the second thing that I mentioned was the rise in the importance of evidence-based medicine. And I'm not going to go into a full recapitulation of how EBM developed over this time. Suffice to say that this gave rise to clinical decision-making tools and the rise of clinical best practices for treating certain conditions. In the tobacco cessation space, primary care physicians took the lead in developing a clinical protocol for addressing nicotine dependence. It says here, tobacco use and dependence. We've been focusing on tobacco use in the past, and I want us to focus on tobacco dependence. So as I say in every training, except for one, this is not a 5A's training, but knowing and understanding the 5A's and how they work to improve the odds of a cessation attempt is going to become very important. And we will talk about that in the third webinar. In the meantime, if you're not already familiar with the 5A's, allow me to introduce you to, or reintroduce you to, the resource pictured on the screen. This is Treating Tobacco Dependence Clinical Guidelines. The original publication of this manual came out in the year 2000, the 5A's themselves having been developed and studied during that critical period in the 90s, after nicotine dependence was an acknowledged psychiatric issue and evidence-based medicine was spreading through the healthcare delivery system. I wholeheartedly recommend this guide as a starter manual for anyone working in tobacco cessation, even from the perch of public health. This manual describes a lot of things related to tobacco initiation and use and experimentation, but it really does do a great job really exploring the 5A's, how it should be done, and it provides a lot of the academic and practice-based support for how it works and why it works, right? The other thing that is nice about the 5A's is that it was developed by physicians for use in primary care sites during routine visits. If the 5As can be successfully deployed in that space, where provider-patient encounters are so short and are almost always precipitated by non-tobacco issues, then there is almost no space where the 5As can't be deployed. In fact, in the years since this publication was released, there has been a lot of practice-based research that demonstrates that the 5As can be successfully deployed for any of multiple preventative and chronic care management situations and in multiple care environments, including in lay community health. And lastly, we need to talk about the social determinants of health and how advances in that area really set the stage for the effective redress of health injustices, generally in tobacco cessation health injustices specifically. With the acknowledgement that socio-environmental or even political inputs can have a much more dramatic impact on health outcomes than that of the medical delivery system itself, came the acknowledgement that proper tobacco prevention and perhaps even proper cessation would have to be done upstream. And it is indeed the case, as I've already mentioned, that the same risk factors that make an individual more likely to experiment, use, and become dependent on any drug are also risk factors for nicotine use and dependence. As long as those risk factors are unevenly allocated across different segments of the population, then nicotine use and dependence will be as well. And therefore, it's worth looking at ways we can enhance the motivation to quit and support quit attempts through programs that look upstream. Something that is less talked about, but perhaps more important, is that many inequities, injustices, as it regards tobacco use, are tied up in the injustices of the health system itself. If tobacco use were some other kind of problem, then we'd be thinking of how to reform those systems. If tobacco use was about food insecurity, we'd be looking for ways to get more successful cessation from the elimination of food deserts. If it was about sanitation, then we'd be looking for logistical solutions to get deeper penetration of our public health sanitation infrastructure. But dependence is a psychiatric condition. We're always on the lookout for some magical solution, one we haven't thought about, or one we haven't tried, the one we haven't invested enough in. I talk to folks who want to find ways to teach kids to cope with stress as a way of helping them to put down their vaping devices. And I've talked to folks who want to do education around sleep hygiene in the hopes that those who use nicotine to wake up in the morning and go to bed at night may be encouraged to leave cigarettes behind once they have a good sleep habit in place. And these are really well-intentioned. They're admirable goals, and they are tangentially related to nicotine use. However, no matter why someone started a tobacco habit, whether it was to deal with stress or to control their depression or to go to sleep at night or to focus on boring school tests that take place too early in the morning, no matter what caused it to start with, when we're working in cessation, we are working in drug dependence, and we have to treat that first. As such, any inequalities in the delivery of psychiatric care, from early detection to continuity of care, will manifest in fewer supported quit attempts, shorter and more unpleasant quit attempts, and ultimately fewer successful quit attempts. I've already alluded to all that, but there is another issue at stake here that's embedded in the same realm of commentary. If tobacco use were safe, then it would matter far less if nicotine were addictive. Caffeine is also very addictive, but all the scientific evidence suggests that the benefits of drinking coffee, at least up to 6 cups a day, outweigh the costs. The most important cost of coffee is really the $7 cappuccino, right? So there's no huge public health movement to ban caffeine. But tobacco products are not safe. Tobacco smoking kills more people every year than all the other behavioral causes of death combined. It causes dozens of diseases, and most of these diseases are chronic in nature, where proper treatment benefits from early detection, and it requires skilled practitioners who know how to deal with complex comorbidities and that can help patients navigate complex care regimens that often take place across multiple care providers. Any deficiencies in the system that delivers that care, any deficiencies that lead to care being disproportionately and systematically disproportionately delivered are going to create injustices in health outcomes that are related to tobacco. All other things being equal, cancers are more likely to be discovered at later stages if the patient is a member of a BIPOC community. All other things being equal, heart conditions, and especially heart attacks, are less likely to be diagnosed in women. Women are less likely to be admitted for a heart attack into the hospital and more likely to be released prematurely. Language and other cultural barriers are incredibly likely to lead to a failure to diagnose common mental health conditions like depression. So here we have a product that causes or complicates diseases, thereby requiring individuals to depend on a healthcare delivery system that has systematically unequal results. And as we'll see, this is not hypothetical, this is real. And we'll talk a lot about this in the next webinar. And that's going to end my remarks for the day. Module 2 will move this discussion into the specific disparities we see in various groups. And it will specifically make the case that nicotine-related disparities are amplified by the fact that since treatment is required to address nicotine use injustices in the health delivery system, then those injustices have resulted in nicotine-related disparities, including lower cessation rates and ultimately worse health outcomes. Yeah, I pushed us right up to the limit, but if anybody does have any questions, you're welcome to unmute yourself, raise your hand, or put it in the chat box.